Sorry if you're all getting tired. And I know the interns have to leave partway through. So feel free to just kind of disappear as you need, although it's a very important topic, in my opinion. I just want to make some acknowledgements. Thank you to Tess and Nina. Their academic half day last year was super helpful for me in developing these slides. And of course, Addie McClintock, as I adapted a lot of these slides from her. So knowing about breast health is incredibly important. Half of your patients have breasts. 1 in 8 women in their lifetime will develop breast cancer. So it's incredibly common. And just thinking about it in terms of health disparity, it's a real place for significant disparity in healthcare. Black women die from breast cancer at much higher rates, and there's more delays in care. This has been well researched, and we find it a lot in the literature. So something to think about, especially as we're addressing the breast care needs of our patients and thinking about breast cancer screening and risk. So the objectives of this talk, and I'm sure, can you guys actually, the objectives of this talk are really, to think about when a breast exam is warranted, how to address when a patient has symptoms, when to screen, start screening and how frequently to screen, and then when to consider a referral, whether to genetics or a breast specialist. So the clinical breast exam, you walk into a patient room and it's an annual and they're wondering if they need a breast exam. And so it's something I think about when I walk in, should I be doing these? And to be quite frank, I don't do them very often. So the clinical breast exam, obviously you're going to do it if someone reports any symptoms or any abnormalities, but there's really not a lot of evidence about benefit in addition to just regular screening when they're due for it. There's no mortality benefit for doing an annual breast exam. However, there's different guidelines. And so I think just having the shared decision-making with the patient, discussing what you may find on a breast exam and whether or not it's worth their time. It might help allay some anxiety for patients. So some still like to get a breast exam and others feel relieved that it's not part of my regular screening. And in terms of self-exam, we previously told people with breasts to check their breasts monthly around their time of cycle, but there's actually no benefit in that. And now I say, really, I encourage breast awareness. So I say, know your breasts, know what feels different and normal for you, know kind of how they change throughout the course of a month, but you don't need to be going in a pattern and, in the shower with soap. It's just really knowing what they're doing. And part of that breast awareness is really knowing when things are different and signs and symptoms to look out for. So again, the clinical breast exam, we've got, many different governing bodies that say, do it yearly, don't do it. We have no recommendation. There's insufficient evidence. And so again, it just speaks to the need for shared decision-making with your patient. So symptoms that do warrant a workup and symptoms that I tell patients to look out for is, to feel for any new lumps or bumps, which you all know about, any breast swelling or changes, any skin changes, skin dimpling, red skin, dry flaking skin. Obviously, we know if it looks like that orange peel skin that we talk about, any nipple retraction or changes, any discharge from the nipple. And then one thing people don't always know or think about is just any breast pain. So any discomfort or pain in the breast. And so thinking about mastalgia or mastodynia, as it is sometimes known, if a patient presents to me with breast pain, things I'm going to ask about are, is it cyclic or non-cyclic? And what that means is really as they cycle through their menstruation, are they noticing a change, like they're getting pain right before their periods? If they're not cycling or they have an IUD, you think about just if the pain is changing over the course of time. Is it different certain times and other times does it change? And then otherwise, I think about, is it focal or non-focal? So is it in both breasts? Is it kind of diffuse? Is it just one breast, or is it certain areas of the breast? And so those are the important 2 questions I ask when I'm asking about breast pain. And then in terms of history, age is incredibly important. Thinking about breast trauma. So if they, had their breast hit recently, sometimes that can cause pain or any increased exercise. I asked about whether or not they're using like undergarments. I didn't put that there. And then lactational status, and then when their last period was. Differential is really broad. So hormonal changes, both associated with pregnancy, but also with medication. So thinking about birth control pills, any trauma, I think about cysts or duct ectasia, any mastitis, which I learned you can also have when you're not lactating, any ligamentous stressing, and then thinking about breast mass as well. When people present with breast pain, having breast cancer related to it is not common. It's like 1 to 5%, but it's something absolutely to have on your differential and to make sure you rule out if someone is presenting with pain that is of concern. So let's start with a case. You've got a healthy 28-year-old who presents with right breast pain for the last 3 weeks. No breast trauma or nipple discharge. They're nulliparous. They have regular menstrual cycles on combined OCPs, and they have really no past medical history. In terms of family history, this patient's mother had breast cancer at 58. There's no other family histories of cancer. There's normal vital signs on a physical exam. BMI is 25. For the breast, you really don't notice anything on your exam aside it's mildly tender to palpation at the right lateral breast. So which of the following is the appropriate next step? And you can answer it in the chat. So are you going to do a screening mammogram? Are you going to do an ultrasound, an MRI, a diagnostic mammo and ultrasound, or just offer supportive care? Oh, we've got a generic.
I launched the poll.
Awesome. All righty, that should be enough time for me to see the result. Yes, absolutely. So ultrasound is the correct answer. If I can get to the next slide. There we go. So this patient has focal pain. It is focused in the right breast. It's non-cyclic in a sense that it's been going on now for 3 weeks. So it hasn't really changed over the course of the time. And this patient is less than 30 years old. So that's when you're going to think about just doing an ultrasound to guide your management. So this key difference really in thinking about this is it diffuse or focal? And that makes a big difference for what your workup's going to be. So with this patient who has focal pain, you essentially consider it a lump equivalent. If you found a lump on a breast exam, you're going to offer diagnostic imaging. So in the same point of having localized pain, you're going to offer diagnostic imaging. With diffuse pain, if it was in both breasts, let's say, you can think about bra fit, think about some hormonal changes and offer symptom management, but generally you're not going to do a full diagnostic workup if you're finding pain in both breasts. That's sort of everywhere. So let's do this case again, but this time the only difference is that this patient is 31 years old. What would you offer now for this patient specifically if they presented with the breast pain? All right. Okay. Absolutely. So you guys are already know exactly what's going on. So you would offer the diagnostic mammogram in addition to the ultrasound. So again, the only difference here is age. It's focal pain, it's non-cyclic pain, and they're over 30 years old. So you're going to do the mammography and the ultrasound. And that's another key point is that the difference for age guides whether or not you also add a mammogram. So if they're under 30, you do the ultrasound only. And if there's anything concerning on ultrasound, you take the next steps for mammography or biopsy. But otherwise, if they're over 30, that's when you automatically order the ultrasound and diagnostic mammogram. So here's just sort of the flow chart about how to manage breast pain or work up breast pain. You're really focusing on the right side of the chart, which is, is it cyclic or non-cyclic? Is it focal or non-focal? And if it is non-cyclic and focal, you're going to think about their age and order the right next step accordingly. With breast pain that's cyclic or non-focal, you're generally going to want to monitor their symptoms, but there's no need for any initial diagnostic imaging. So here's the next step. So her diagnostic mammogram and ultrasound reveal small, uncomplicated, simple cyst in the right breast. Her breasts are heterogeneously dense. How do you counsel her? Proceed with biopsy, start annual screening mammogram next year, topical diclofenac and a supportive bra, and avoid caffeine. Okay. So I see some for topical diclofenac. I see some for avoid caffeine. And you are both right. So generally, the gold standard is really offering some topical NSAIDs, ensuring that patients are wearing supportive undergarments, that their bras aren't too tight. A poor fitting bra can actually make a big difference. And a lot of lateral breast pain can be secondary to sort of that ligamentous stretching. This patient obviously had a cyst that was visualized. It was simple though. So there's no indication for further sort of diagnostics or anything of that sort. And then thinking about avoiding caffeine. So no randomized controlled trials have demonstrated that caffeine actually is associated with breast pain, but some patients anecdotally report improvement. So if they can avoid caffeine, which I admit is pretty hard, you can just offer that as a potential option if they continue to have pain. Sometimes just having the imaging itself is reassuring for patients, and they find that with time, the pain is managed or it goes away with time. Another thing is evening primrose oil, which I'm not exactly even sure what it is, but that's something else you can offer patients if they're interested in sort of more alternative medicines. Again, no RTCs have demonstrated its effectiveness, but some people say it's been useful for them. So getting into breast cancer screening, I think it's important to recognize that there's many guidelines for breast cancer screening, and these guidelines really are to apply for women of average risk. So that's the thing you need to think about when you're thinking about when to start mammograms for patients. Is this an average patient, or is there something else I need to think about in terms of their need for screening? So, like I said, guidelines differ, but there's no right or wrong answer. It's just a matter of knowing what the guidelines are and deciding with your patient what's going to be best for them. So being aware of who is and isn't average risk, because again, these guidelines for screening are for average risk women. And then thinking about if people are above average risk, what is the next step to support them and potentially supplement their screening. So the screening guidelines, I feel like we've all seen these before. There's a lot of different ones. Do you start at 40? Do you start at 50? Do you do it every year, every other year? Do you stop at 75? I feel like in primary care, we generally say, let's follow USPSTF guidelines, and this is how we do it. But I think we really need to consider, that shared decision making again with the patient, and take a good history to assess risk to better, I think, counsel patients around what sort of screening is best for them. And thinking again about women that are African American or Black, looking at the disparities that we're seeing. They're often diagnosed at a younger age, and we're obviously seeing that more Black women are dying of cancer than white women. And so with that sort of shared decision making model, considering offering screening at the younger age, so at 40 for women that are Black or African American. Again, just having that conversation. So thinking about a case, so that same patient you saw who had the breast pain in her 30s, in a few years, she returns to the office for her wellness exam. She's 40 years old now. She's wondering when she should start breast cancer screening. Since you saw her, she's had 2 children, now has an IUD. She gets regular menstrual cycles, but no longer any breast pain. Remember, her breast density that we saw on her diagnostic mammo was heterogeneously dense, and her only history of cancer is in her mother at 58, breast cancer. So how do you decide on her screening schedule? So do you start mammograms now? She's 40, her mom had cancer. Do you start screening mammograms at 50? We like to follow USPSTF guidelines. Do you calculate her breast cancer risk? Do you refer her to genetics? Her mom had cancer, something to think about. Or do you refer her to a breast specialist? Great. So I agree. I think there's really no right or wrong answer. Looks like most people are voting for calculate breast cancer risk. Exactly. And discuss those risks and have shared decision making with the patient around when you do start screening. So assessing risk. Admittedly, a lot of people I feel like aren't assessing risk. We ask about family history, but specifically for breast cancer, we don't always go into it. We just say, oh, we're doing mammograms now. So I'm hoping that this is sort of like a little antenna that goes up that says, I should think a little bit more about assessing risk. And sometimes it even warrants a separate visit. So, a patient may say, oh, I have no family history of cancers, and that's enough. But if someone says, oh, I do have, I've got a significant past medical history or a bunch of cancers in my family, that's when you can consider having them come in for a full separate risk stratification visit. But basically, in terms of assessing risk, you are going to ask about their own personal history. So, any history of cancers, if they've had any breast biopsies with any abnormal tissue, have they had chest radiation in the past that automatically makes them high risk? And then what is their hormonal history? When did they have menarche, menopause? How many kids have they had? And have they had any hormonal replacement therapy? And then their age. Age is one of the biggest risk factors for breast cancer. And then getting into family history, you want to take a good 3-generational family history. The age of onset of the cancer, was it pre or post menopausal? Was it on one side or two? Any other cancers? Any multiple cancers on a single side? And that means even on their father's side. I feel like a lot of patients are like, oh, I've got cancer, but just on my dad's side. It's just as relevant. And so making sure that you're getting that full history, and then asking if any genetic testing has been completed. Admittedly, a lot of patients don't know their full detailed cancer, like family cancer history, and that's okay. It's just trying to kind of get into it a little bit. So when to refer to genetics, I think it's important to know when, and there's different guidelines. But basically, if something's coming up, you're like, there's a lot of cancers in this family. That's when you should think, I should look and see if they would qualify for referral to genetics, even just at baseline. So, obviously, if there's a known mutation, if 2 or more primary cancers in one individual in the family, and thinking about if, her mom had breast cancer in both breasts, that would be 2 cancers. If anyone on the same side, if there's 2 relatives with breast cancer on the same side with one less than 50 years old, so sort of essentially premenopausal, any premenopausal breast cancer / before 45, any ovarian cancer in the family, and then male breast cancer, pancreatic, or metastatic prostate cancer could qualify you for a referral to genetics. And then just looking at 3 or more relatives with cancers, especially if they're early. So if it's sort of like, patients saying I have a lot of family cancers, that's when I would think about going through all those cancers and potentially referring to genetics. It's surprisingly easy to get a genetics referral, and there's some easy ways to do it. So there you go. But for us in the office, one thing we can do is generate risk through these risk calculators. One that I like to use that's really quick and I don't think requires a separate visit is the Breast Cancer Surveillance Consortium, or BCSC. It's an easy place to start in primary care. And usually I'll do it just if there's one reported family history of cancer. So one first-degree relative. So for this patient who has, her mom had cancer, that's the only one reported, I would use the BCSC for her. It does take age, density, and any biopsy history into account. And so recall that she has density because she had a diagnostic mammogram. A lot of your patients won't have density. There's also the Gale risk calculator, which you could use. But sometimes people say, just if someone's 40 and you're talking about their risks of cancer, you could consider getting their first screening mammogram at 40 to know what their density is. And then you can use that density data to develop the risk calculation to guide future screening. And then the second one is the Tyrer-Cuzick. This is often reported actually on the mammogram. And I'm not sure how accurate it is on the mammogram results because patients report that they're not always getting into the history. But this is really better for patients with an extensive family history because it takes into account a lot more details. This takes a lot more time though. And so I recommend, if you are going to go through this one, having a separate visit to really calculate it with the patient. All right. And in terms of risk categories, so there's average, intermediate, and high. So for average risk, again, lifetime risk less than or equal to 15%. So it's still, we have women have a high lifetime risk of breast cancer, but the average risk is at less than 15%. And you're going to see that you just do routine screening per average risk guidelines. And so talking with the patient about which guidelines they prefer and how frequently they feel would be best for them. With intermediate risk, that poses a little bit more complication. So, again, that shared decision making, I would consider recommending starting at 40 and doing the annual screen if their lifetime risk is intermediate. And sometimes they'll ask you about whether or not they should be getting MRIs or ultrasound, and there is insufficient evidence for intermediate risk patients getting those imaging. So not necessarily something you should be doing, and not something I do. And then for high risk women. So remember, women with any history of chest radiation are automatically high risk. But these are people who come out at a lifetime risk of greater than or equal to 20%. For these patients, you're going to do an MRI and mammogram alternating every 6 months, starting 10 years before the first diagnosis of breast cancer in the family, but you don't start before 30. And these are the patients where I say I should refer to a breast specialist. There's potential for chemoprophylaxis, so medications that they can take to decrease their risk of breast cancer after they're finished with childbearing. And so having them speak with a breast specialist about what their options are, I think can help alleviate some anxiety or stress for the patient, and just provides better information for you in terms of conversations and guiding screening goals. So to summarize, and I apologize if I rushed a little bit through this, but I'll open it up to questions in a second. So first, with the breast exam, you're definitely going to do a breast exam with symptoms. And for screening, it's really if it's in line with the patient goals. So I offer it to all my patients, but I clarify that there's no mortality benefit, and I let them decide if it's something they want to do. For breast pain, if it's non-cyclic and focal, I'm going to do an ultrasound for all my patients and a diagnostic mammogram if they're over the age of 30. So know that age and type of pain is going to guide what we do. And then for screening guidelines, I think just remembering that they're for average risk women. And I think we just automatically assume women are average risk, but we really should be using a risk calculator to guide our screening plan. And it's a pretty quick, easy thing we can do, particularly the BCSC. And then lastly, consider genetics and or a breast referral for qualifying or high risk patients. So have that red flag go up if they're reporting a lot of history of cancers in the family, and think about getting them tested and having that consultation. All right, and that's it. So if you guys have any questions, I wasn't monitoring the chat, but I don't know if there was anything there.
There was a question about breast cancer risk tools, which you addressed on that next slide.
Oh, good. That simple, no questions. Did I go through too fast?
You did a great job, Sarah.
Okay.
So